Thank you for joining us for the Ohio ACEP Fellowship Zoom. Today's Zoom will be focused on critical care fellowships. Our resident advisory group identified this as an important topic. I would like to thank the panelists that accepted our invitation to speak today. And I would also like to thank the chair of our Candidate Young Physician Committee, Dr. Bob Jones, as well as our Ohio ACEP resident board member, Dr. Randall McComb. Dr. McComb is going to begin our conversation to get us started, but please feel free to raise your hand or put your questions in the chat. So I'll go ahead and kick it over to you, Dr. McComb.
Cool. Yeah, thanks everybody for showing up. I appreciate it. We had quite a few residents that had registered for this. They're not here. Hopefully they kind of trickle in, but this is recorded. I'd like everybody to kind of go around and introduce themselves with their title in terms of like what kind of critical care physician you are and where you work. And then let's do popcorn. So I'll pick the first person and then afterwards you pick the next. Is that okay? Cool. So let's go with Dr. Matthew Stoll.
Hi guys, my name is Matt Stoll. I am a EM intensivist here in Cleveland. I'm at University Hospitals at Case Western. I am actually the residency program director as well as still an actively practicing EM intensivist. I split my time between the ED, not surprisingly, as well as the I'm entirely in a cardiothoracic ICU at this point. So all of my ICU time is in sort of patients that are sick, mostly post-operative, but it's also our only home for VV and VECMO at UH. And so I really enjoy mechanical circulatory support and everything that comes along with that. So that's me. Oh, my job is to pop it over to, how about Brad?
Perfect. All right, guys, it's nice to meet you. My name's Brad. I am actually a first-year fellow over at the University of Cincinnati. Did my EM training down at Akron General, so just making my way through Ohio, kind of born and raised in Cleveland, so, you know, can't get enough. The majority of my time is anesthesia-based, so I went through the anesthesia critical care pathway, and similarly spend a majority of my time training in the CVICU, but of course rotate through all the other ICUs, and have a focus on MCS and, you know, other stuff like that. I will go ahead and popcorn it over to one of my attendings, Dr. Bonomo.
Hi, Jordan Bonomo. I'm a professor of emergency medicine and neurosurgery and neurology at UC. I split in Cincinnati. I split my time between the ED, the neuro ICU, cardiothoracic ICU, and ECMO service. I'm also one of the stroke team physicians. And October 1, we are opening up our Flex ICU, which is our emergency department-based intensive care unit. It's a full-throated 12-bed ICU based in the ED, at which point I will actually stop working in emergency medicine for a year or so, so I can focus on getting that ship up and running. Let's go to Dr. Posey.
Dr. Posey, yes, please.
Yeah, I am not a physician. I actually work with Holly at Ohio ACEP. I'm her counterpart here. But thank you. Not a physician, but happy to be here and see you all. I'll pass it on to Dr. Bushra.
Excellent. Hi, guys. My name is Marina. I am an EM IMCCM attending. So I went the way of the internal medicine route. I split 50-50, 1 month in the ICU, which is all medical for me, and 1 month in the emergency department. And I'm at the Cleveland Clinic conglomerate, including main campus and Fairview. Dr. Case.
I am James Case. I am critical care. I am and have been a full-time intensivist at ProMedica Toledo Hospital for probably almost 10 years now. And I cover the one of the medical ICUs as well as one of the cardiac ICUs. I don't do the post-operative heart surgery patients. My cardiac ICU is strictly medical management with a small amount of MCS as well. So I will kick it over to Dr. McCloskey.
Hey folks, I'm Colin McCluskey. I, similar to the good Dr. Stahl, work at University Hospitals and Case Western. We have similar roles. I still work in the ED half-time and then the cardiothoracic ICU. I'm the medical director of our systems ECMO services. So I get a little deep in admin-y on that side of things. But I'm happy to be here with the community of EM critical care. Looks great.
Perfect. I think our last person is Dr. Jones, if you wanted to introduce yourself and we can get started.
Hi, I'm Bob Jones. I'm an EM physician at Metro Health, and I am not a critical care trained. So I am here to just help with the Zoom. So, but thank you guys for attending.
Yeah, I appreciate it. So we're going to kick this off. I've got a few questions, and it sounds like we have a mix of anesthesia and internal medicine pathways, so that'll be good for our first question. And it really can just go up to whoever would like to talk about it. So my first one is, what benefits or downfalls does an IM critical care pathway have over an anesthesia critical care fellowship?
I don't know that you can necessarily call advantages so much as it is deciding what it is that you want to do. The nice thing about coming out of EM is that all of the critical care pathways, including neuro, IM, anesthesia, and surgical, are open to us. Although this coming year, the surgical pathway becomes one where you do a surgical intern year, followed by 1 year of critical care, which I personally think is inadequate for critical care training. And who wants to go through a surgical intern year anyway? It's up to, if that's like your passion, that's fine. But I do think we will see a lot of people switching out of the surgical critical care route to what I'm going to assume is probably more the anesthesia route. You can get ready to be any kind of critical care doctor out of any of the pathways. So I have friends that graduated IM critical care with me that work as ECMO specialists, that work in cardiothoracic ICUs, that work in surgical ICUs, and that work in medical ICUs. But I do feel like you're going to get a significantly more rigorous training in post-surgical management in the anesthesia fellowship than in the IM fellowship. Could I learn to run a surgical ICU if you give me enough time? Sure. But I feel like coming out of anesthesia, that training is a little bit more robust. Like Dr. Case, I do take care of some cardiac and a little bit of mechanical circulatory support, but that is not the meat and potatoes of what I do.
I would second what Dr. Boucher said. I think the big part of it is, if you have an idea what type of ICU you want to work in when you are finished with your fellowship, that you should choose a fellowship that helps to support that. The anesthesia-based programs are very solid in the post-operative management, and depending on the fellowship, may be much stronger, much stronger in the some of the mechanical support side of things, such as ECMO and whatnot. My program was strictly medicine based. We were not an ECMO program. They may be now, but they were not at the time. So I got very, very little experience with ECMO. So whenever we have patients now that we're putting on VV or VI ECMO, they end up going to our cardiac surgery ICU. And because of the way our hospital is set up, we almost invariably are transferring these patients within hours to other facilities. Most notably over to UH, just because of logistical support. So Dr. Stahl, thank you very much for accepting my train wrecks. But I think that one of the big advantages to the IM pathway is the knowledge base that's going to expose you to. Just like the anesthesia pathway will expose you to a more intense post-operative management, IM is going to expose you to an area where EM is not so strong. When EM residents are finished with their residency training, I feel they're very comfortable taking care of unstable, sick, crashing patients. And that's going to give them a leg up in areas over maybe some of their other classmates, not just from a procedural standpoint, but just from a comfort standpoint of somebody who has, blood pressure in the 50s and SATs in the 70s. They've seen that before. They're used to dealing with it. They know how to manage that. But a week later, when you are dealing with acute kidney injury or some kind of strange anemia or some infectious disease issue, these are areas where EM is not so strong. And a lot of the pediatric and OB training and things like that that we may be that we may pick up on in EM isn't going to carry over. So there's a knowledge gap there between the EM and the IM residents when they first start these IM critical care fellowships. So I personally, I'm a bigger fan of the IM pathway strictly because of that. And it gives you more exposure to some of these other specialties like nephrology, hematology, infectious disease, things like that, that we really don't have a lot of exposure to in the ER, but are going to be a big part of management in the ICU, especially beyond the first 24 to 48 hours.
Yeah, that's a good point. Anybody else want to chip in?
I'm going to take the heretical view because I love to be the heretic. And some of this is being trained under Jordan Bonomo. But the reality is, I think this is all is a false idea of anesthesia versus IM versus critical care is critical care. We are excellent at shock states, organ failure, whatever it may be. Yes, have I spent a little more time with MCS than because I did an anesthesia critical care pathway? Maybe, but I am a big believer of go to the program that prepares you and sort of, just makes you see the light of critical care. And to me, that's the programs that really lean into multidisciplinary critical care, because I think that's the future. I think we need to get away from this sort of siloed, only the people that have done medicine needs to be in the MICU and vice versa. I gained so much from being around medicine doctors and anesthesia doctors and surgery doctors in my fellowship, and seeing how they thought was so valuable to me. So I'm just a big believer of finding the program that truly makes you the generalist that we are coming from EM having. I think it's great to maintain generalism, quite frankly, because we're like the rainbow unicorns by coming from EM. We're the ones that can deal with anything. And maybe if you're doing critical care, you are doing it specifically to never see kids again or never have to take care of a surgical patient again or anything like that. And maybe that's true. And then there are right programs for you. But if you're doing it to maintain the generalism that we get from being great emergency physicians, then I encourage you to keep looking for that multidisciplinary program. And a lot of them are out there. I think they continue to sort of grow in terms of the number that are truly multidisciplinary in that sense.
Yeah, those are great points. I can agree with all of that right there. It sounds like pick what you're passionate about and what you want to do and where you think you'll be trained best rather than just picking one over the other. Cool. So I'll move on to our second question. And so again, this is more for the people that interns are coming in and they're curious about internal medicine pathway versus anesthesia or the other ones that are coming up. Is which one is it harder to get into, internal medicine or the anesthesia pathway?
I think the biggest impedance to the anesthesia pathway is if you do not want to take a year off and you are in a 3-year EM program, because they match through the San Francisco match 2 years prior to the initiation of your class. And I'll defer to the anesthesia guys, but I have worked with 2nd-year EM residents to get their applications ready for a critical care fellowship. And it's hard with a year and 2 months of experience to really justify knowing that this is the thing you want to do for the rest of your life.
Yeah, I would piggyback on that. Is it hard to get into anesthesia critical care? No, there were a lot of unfilled anesthesia critical care spots last year. And I think a little bit of that, Dr. Bruscho's point is we are seeing an influx of EM folks going to critical care, and the San Francisco match having to make that decision so early, I think limits the pool. So I think that's a little bit, of an issue there. But I think less anesthesia versus IM, it's really going to be program and geography based, right? The programs that folks have heard about are going to be more competitive, and the programs in places where a lot of people want to live are going to be more competitive. Not that Cleveland, Ohio isn't the place everyone wants to live, but there are other places that if you're, wanted more training, people at first breath look towards. So I think it's more based on the same stuff for residency, which is it a name program, and where is it in the US is going to drive a lot more of the competition than, what board exam you're going to take in a couple of years.
As someone who just kind of went through this within, gosh, the last like 2 years or so, totally agree with both of those points. I think if you're starting out as an intern and you want to match anesthesia, it's a really kind of quick time frame. And you have to kind of work with your program to organize yourself as such, because that application comes up in the middle of that second year. And then to Dr. McCloskey's point, the programs that are well known for good EM critical care, whether it's anesthesia or IM, are going to be tough to get into because people are going to kind of navigate there. And then certainly geographic, like he was saying. Statistically, anesthesia is easier to get into. IM is a little more difficult. And I think that partially stems from, incentives that anesthesia residents or IM residents have for going into critical care outside of just the academia of it. It's a little bit less incentive from like a financial and time standpoint for anesthesia residents to go to an anesthesia critical care, maybe a little bit more so for IM too. So that always comes into play with the flux of matching over the years.
That's good points. Okay, I think kind of moving along here for my third question is really how heavy does the ITE weigh in on my application?
I don't know that I have ever looked at anybody's IT score looking at applications.
That's encouraging.
Yeah, I'll say as a fellowship director who mercifully just gave that to someone else and I'm no longer a fellowship director, I looked at them all the time. And I just wanted to make sure that I knew who I was going to meet that day. And in theory, we used them to just have a rough idea that they were able to do the work well enough to interview. I never didn't offer an interview because someone had a low IT score, and I never offered one simply because someone did have one. But it's nice to know how that matches against their personal statement and their letters. If someone's IT score is super high and their letters are mediocre, it can actually be kind of harmful. I'm wondering why you've got such a rock star intellect, but doesn't have the workhorse mentality. And the opposite is also true. If someone has a reasonably low set of ITE scores, but they're said to be the greatest teammate ever, and they work harder than anyone else, that actually is a big bonus. I think you have to take them. They're not going to keep you out of programs, but they are certainly something that we do look at from a fellowship director standpoint sometimes.
Yeah, similar to Dr. Bonomo, like I look at them and I want to see if you can pass the test, because in 5 years about my program, they're going to want to know, did your graduates get boarded? And so there is a test part of that. So I want to know, can you pass the test? But am I going to decide X versus Y based on ITE score? Absolutely not. It's going to be the interview, the letters of recommendation, all those kind of things that actually look at, are you a teammate? Are you a good human? That carries more weight than your acumen on a standardized test, as long as you can pass it.
I agree. Okay. Moving on to the fourth question. So correct me if I'm wrong. I'm not an ICU or a critical care applicant, but so if I were to go into anesthesia, right, and then wanted to do an anesthesia critical care fellowship, it would just be 1 year for me. So if I'm an EM applicant applying to an anesthesia critical pathway, what does that second year look like for me in terms of like the curriculum and everything else?
So from at least like our program standpoint, a lot of it is kind of the repetition and the same. with a little bit of a higher degree and maybe the leadership component taking over in charge. And, we have certain like a catchment radius where we're accepting patients from. So kind of playing more of a logistic role in that standpoint. And then we also have time to do a little bit more elective time to fill in some of those knowledge gaps that you kind of learn about yourself in your first year of fellowship. So if maybe you're not as comfortable with your TEE knowledge, you can take 2 weeks to, get more TEE experience or, nephrology experience, so on and so forth. So it's a little bit more flexible in that, right? But it is kind of just adding more volume, which of course is always helpful when there's such a wide breadth of knowledge to kind of figure out.
Yeah, people, I think, rightly so. Don't get me wrong. I mean, I think EM docs would make good intensivists with a single year of fellowship, because if medicine does 3, et cetera, but if all these specialties only need 1 year, they're just getting by, quite honestly. When I work with colleagues who are fresh out of these 1-year fellowships, they just are, they are uncomfortable, but still growing. I find I left my fellowship after 2 years of critical care, and I was ready. I was ready to teach. I was ready to round. I was ready to really be the full intensivist. Don't get me wrong. I'm developing every day. I'm still growing. But I think ultimately, I see people sometimes get bitter about EM needing these 2 years, and whether it's appropriate or not, whatever, those 2 years make you a better intensivist because you just get more well-roundedness. You are able to lean into to Dr. Polako's point. If you are uncomfortable in the MICU from anesthesia, spend more time in the MICU. If you're uncomfortable in the SICU, et cetera, et cetera. So I think it's really valuable, those 2 years. And I would not, admittedly, I did 2 fellowships, so I'm a nerd and like to train, and I probably would have done a 3rd, but I just had to get a real job.
I think to the question of what does that second year look like, it's going to depend on the fellowship, right? Ones that are just purely matching EM folks, you may have a 2-year longitudinal, curriculum that builds upon it. Our fellowship is a mixture of 1-year anesthesia folks, integrated 18-month anesthesia folks, and then 2-year EM folks. I wasn't going to create one curriculum for each of them. And so what we do is we have 1-year curriculums that we repeat. The bonus of EM is 1, you get spaced repetition. And then 2, with the clinical side, with your electives, you get 1 more reps. And then 2, as you start to develop from a pluripotent stem cell to one that's a little differentiated, you can then kind of craft things. Do I want more MTS time? Do I want more time? Dr. Phil's point in the NICU, if I think that's the population I'm going to serve. So I think it gives you a little bit more time to speciate the way that you want to in that second year. But as far as from a curriculum, from a didactic side, that's going to really be program dependent and the learners you're sharing that curriculum with.
Okay, those are good points. Thanks, everybody. Moving on to the 5th question. Really, this is personal. So what do you feel critical care has brought to your professional career?
Sorry, I didn't mean to giggle, but on the 4-year anniversary of the announcement of the lockdown for the pandemic, I can tell you what it brought the last 4 years. PTSD and counseling. And I don't mean that actually totally farcically. I think that critical care brings with it a set of stressors that are very different than the ones we have in emergency medicine, although they're related. It's a wonderful balance. I often say that the work we do in the ICU is a nice balance of the physical beatdown of the ED, where you're moving 30 patients in a shift and trying to move as fast as you can. Sometimes you don't have time to think as much as you want. You certainly don't have time to engage the way you want. In critical care, you have more of that time. But it brings a whole nother set of stressors with it, right? You don't leave it at the hospital. Your phone doesn't necessarily turn off at night. You're dreaming about vent settings and what's going to the next step with your patients and trying to get them out of the unit. And you have these deep connections with families that go well beyond their time under your watch in the ICU. I think it brings balance ultimately to do critical care and emergency medicine in the same career.
As the kind of outlier here that is the full-time intensivist instead of the person that splits their time back and forth. I take a little bit different view on this, and for me, it was a way for me to get into a career that I feel matches my personality and my lifestyle. But similar to what Dr. Bonomo was saying, I think it provides a lot of leeway to help offset a lot of those enormous stressors that come from working in the ED. When we know that the burnout rate for ED physicians is insanely high, and part of that is because the nature of the work that is being done. Part of it is the lifestyle and the shift work, and having the ability to flex between the ED and the ICU, where things can still be chaotic, but they're somewhat more structured. I know a little bit more what my day is going to look like when I walk into the ICU every day. I think has enormous career benefits, and I think it's going to help provide a lot of long-term satisfaction because you're not constantly getting beaten down when you're in the department. But there's also I personally really enjoy some of the longitudinal effects of watching and taking care of my patients. I take ownership of my patients. It's not just I come in, I have my shift I work, I have these patients on my list that I have to see, and then I'm done. It is, I have a vested interest in making sure that they do well. And seeing that plan that I start on the first or second day of the week, how that plan adapts, how the patient responds, the relationships that we build with families and with patients along the way are one of the most rewarding parts of my job. And I really missed that when I was still working in the ED.
I think I'm a way better EM physician because I'm an intensivist, and I'm a way better intensivist because I'm an EM physician. I mean, I'm obviously biased. I run a residency program and tell people like this is a great lifestyle, but like I think it has prolonged my clinical career probably by decades because I have this fulfilling side hustle that is critical care. I mean, EM, in my opinion, is getting harder and harder and harder to do. Not that critical care is any easier, but the dynamicity, the ability to be, you know, I just came off a week in the ICU, and like that fills my cup in a totally different way than going downstairs and just like knocking out a bunch of like, you know, STD checks and UAs and things like that and dispoing people left. You know, like if you like that aspect of the practice, I think it's really fulfilling to, you know, bounce back and forth between the two. Because I think if I was just in the ED, I'd be, you know, heading for burnout pretty quickly. If I was just in the ICU, I think I equally would be. So that dynamicity is to me what keeps the career being longitudinal and meaningful.
I'm gonna second Dr. Stoll. I'm one of those people that just EM is the love of my life. And I didn't get into critical care to not do ED, which a lot of people do, and is a perfectly valid reason to go into critical care. But I love bouncing back and forth because it has taught me to think in different ways, right? I'm very conscious of the way that I'm thinking and the way that I'm approaching patients, and actually give a lecture to the EM residents called My, if it isn't the consequences of my own actions. Because my friends, I am a fantastic resuscitationist. I'm sure all of us are too, but there is a time and a place for that. I don't think we appreciate that as much in the emergency department. What the end products of some of those resuscitations, what the end of life of some of those resuscitations end up looking like. And so it's given me a little bit of a more big picture perspective, and not just the airway breathing, you know, CT disposition mindset that sometimes I have when I'm in the emergency department, but really where are we going from here for your life goals in critically ill patients?
I think obviously I agree with everyone who's seated here, but I think the ability to collaborate on different projects really improves when you're a member of different tribes at the same time. So for example, because I'm a critical care doctor, I'm now on the ECMO side, and I get to work with our cardiothoracic surgeons, our interventional cardiologists, our heart failure cardiologists, our transplant folks. And that's, bequeaths a lot of opportunities for projects across service lines that are, they're really fun and they're really fulfilling, because you get to meet all these folks and truly collaborate, across those things. And not that you couldn't do that with just EM, but there is a credibility in being a teammate when you take care of folks upstairs in those contexts that gives you some credibility that you're going to offer value and offer some insight. And that's filtered down to, the ED. We're able to help our folks in the ED because we see that longitudinal reasons. If it's, to Dr. Bruce's point of maybe we shouldn't do this, to hyper-aggressive things or system-wide interventions like Dr. Bonomo is doing with the Flex ED. You can see those gaps in a way and then collaborate across service lines to actually make things happen in a way that if you're only member of one tribe, you probably wouldn't be able to move that needle.
I will second that even though I don't work shifts in the ED, having the ED background definitely gives me some additional street cred and credibility when it comes time to dealing with interactions between the ED and the ICU. And yeah, you can go down there and you can see patients in the ED, and you can make your face known and you can build up some credibility that way. But actually having been there, done that, definitely helps bridge the gap between those two service lines, because they are closely related and they do interact very heavily. And as part of just making things better, having that ability to help coordinate between, okay, I see the resuscitation side downstairs and I see the longer term care upstairs, having the ability to walk in both worlds has been very, very valuable.
Yeah, I love being the voice upstairs that provides perspective on what it is that we do downstairs, right? Because everyone thinks they know. Everyone, like, let's be honest. I won't put on the program director like chip on my shoulder, but like the reality is everyone thinks they can just do EM because they're a medicine doctor or a surgeon or this, that, the other. But the reality is what we do and what we're trained to do in the ED is so different than almost any other specialty out there. To truly lean into the undifferentiated patient, walk them through that, figure out what's going on, resuscitate the sickest, most undifferentiated patients of all, and get them to upstairs, and never have a pop-off valve, right? Never be able to say, no beds, we're not allowed to take more patients. Like, that is such a unique perspective. And the number of times I hear colleagues or trainees say to me, like, why is this patient not have a central line, A line, and like be tied in a bow? It's like, well, because they had 30 other patients that they were keeping alive down there too. And the number of times people looked at me and be like, oh, that's a good point. That it's just nice to be able to really feel like you're providing the voice of emergency medicine to the upstairs care just as much as it is helping, as everyone else sort of provided the point of like truly elevating the resuscitation downstairs.
Matt, I'll totally agree with you. And I'll add that sometimes it's helpful to translate upstairs to downstairs. So when I'm working in the ED, and I can remind them that we have this idea of what the ICUs are like, right? There's people out there with hot appetizers being passed on trays, you're getting massage, you're just relaxing. It's clearly not the way the ICU works either. And just because they're not moving as fast as the ED wants doesn't mean they're doing something wrong or nefarious. And also, the critical care thinking, especially on the surgical subspecialty side, is very different than ours. So we're looking at an ENT nightmare in the ED saying, oh my gosh, this has to be in an ICU with ENT. ENT comes, looks at us, they're like, that's not patient quad scope, right? And helping them translate what we believe to be the true emergencies in EM versus what the intensivists think of our emergencies or their workflow is actually really helpful too sometimes. I feel like we can do a good job translating and just calming people down.
Yeah, I would echo a few of those things. Just again, is that one, I'm an ED resident, and I thought that the patient interactions, like missing those, really wouldn't bother me. But now that I've had quite a few really special patient interactions, and I'm kind of missing spending some time with patients when it matters. And then 2, we have a couple EM ICU trained physicians in our department, and listening to them talk to the ICU about things and like why this patient needs to go there, or vice versa. When I was on the unit, when they would give feedback to the ED, it is really insightful. So moving on, I got 2 more questions for us here. And so the next one is, with ED overcrowding, do you feel that the ED ICUs will become more common? And do you feel that this could be a career path?
I can take a swing at this one. Yeah, turns out ED overcrowding is a real problem. And yes, it can be a career path. Yes, it can take a really long time. I've been working on this one for 15 years. Seriously, it's a real number. But I'll tell you that, ED overcrowding, in particular, the number of high complexity step down patients who are living in the ED at midnight is a really big number. And many of those patients, we all know, we label them as step down out of self-defense because we know they're never going to get an ICU bed. But your DK patient on an insulin drip that you can close a gap on and get out of an ICU in less than 23 hours is a really nice target for an ED ICU. Those patients that you can bring real medical care to bear on and move quickly through a unit, those are a great patient population that's currently sort of underserved. They don't have a place. Everyone just leaves them in the ED because they know they're going to get better if they follow, protocols are followed, but sometimes they don't. So anyway, my impression there is that, yeah, it can absolutely be a career path. And I think as ED overcrowding continues, as unit overcrowding continues, I mean, every one of us has ICUs that have multi-day waiting lists to get in, and that's not in the setting of a pandemic where patients waited 15, 16 days to be transferred. The ED ICU concept, I think it absolutely has legs. And if you look at the national landscape over the last 10 years, we're building. I don't mean the physical plants, although we're doing that too, but I think the actual impetus to create these spaces, the science and data behind the spaces being effective, both from a patient care standpoint, reduction of hospital days, and financially beneficial to the institutions as well as the patients. The data is so clear that I can't imagine we're not going to build more of these.
I mean,
I would.
Sorry, go ahead.
Go ahead.
James, go ahead.
I would love to see more of these things. The ED ICU is probably one of the few things that would ever get me out of the ICU and get me closer to working back in the ER on a more regular basis. I think there are going to be more and more of these showing up, but when I look at them, yeah, when you talk about it taking 15 years to get to that point, the logistical challenges of trying to set one of these things up, I can't even begin to wrap my head around the logistics that must be involved in these. But I can see how incredibly useful they could become and what a massive resource they would be for the hospital. The issue that I deal with personally, honestly, isn't so much getting people into the ICU, because we can usually get people in fairly short order. And we have a decent sized catchment area all over Northwest Ohio and a good portion of southeastern Michigan. But our problem is we can't get them back out again. That once they're in, we just have no place to put them, because at least at our institution, the floor is the big bottleneck, and those floor beds are very, very much in demand.
We have to remember, it's not an ED overcrowding issue. It's a system overload. And I think that's one of the problems is we in EM for a very long time have taken this on our shoulders and sort of made it about, us just trying to like get by. And that's unacceptable. And I do appreciate ACEP's sort of role in this. Dr. Terry has sort of really done a really good job of saying this is system overload, not ED overcrowding, because then it makes it sound like it's just our problem. And the reality, to Dr. Case's point, we have the exact same problem all the way on the other side of the state. It's not necessarily getting patients into the ICU, because when they need to be there, I will find a way to make it happen. But it's getting them out on the back end that things, are taking longer and longer to move these patients forward. And my belief is, yes, our ED ICUs may be the future, maybe. I think EM perspective in critical care is the future that will be the game changer. That we work 24/7, 365. There's none of this, I round once a day and the decisions get made on the patient. And then if they're better enough tomorrow, they can get out. It's like, if I can dispo a patient at 2 o'clock in the morning and I'm there and say it's safe, they're to be left out of the unit. Because there's actually usually a couple open beds in the hospital at 2 a.m. that ironically aren't there at 2 p.m. when we're like making these decisions. So I actually think EM's like sort of always be dispoing perspective is what is necessary in the ICUs, as opposed to the once a day rounds that surgery and medicine and anesthesia have always sort of adhered to.
So I think
You're muted, Dr. Boucher.
Oh, please, Dr. Boucher, go if you're muted. Still muted. Maybe she's not talking to us.
You're still muted.
Yeah, that would explain a lot of things. Yep. I was gonna say I have a little bit of a personal soapbox on this. I think even if we don't see the proliferation of formal ED ICUs, which I honestly would love to see more of, we're all practicing in ED ICUs. And I think that a little bit of a detriment to the ED mindset is, well, like my job is stabilizing and whatever happens later is really an intensivist problem. But more and more data is coming out that what we do in the ED matters so much. The initial ventilator settings, the initial pressure requirements, the way that we address sepsis, all of that matters. And so I think even for residents that decide ultimately not to go into fellowship at all or not to go into critical care training, it is so immensely important for your practice and for your patient outcomes to be well versed in critical care. Even the minutia of dumb ventilator things, whatever things you want to attribute to like internal medicine things, these things really matter at the end of the day for your patients.
Yeah, I concur with what's been said, but I think as far as the brick and mortar ED ICUs, we tried to stand one up and it fell in the face of no nurses. So a lot of respect to the UC group for sticking with it. But I think the idea of, can you be someone who is going to be solution oriented about the critical care overload? Because I think in 2024 with what's happened with critical care and all of that, you're going to have a lot of flexibility on how to approach this problem. The answer for the system may be a brick and mortar ED ICU. It may be a tele ICU intervention that keeps people. I mean, we're a 24 hospital system. We have a lot of folks coming in from the hinterlands that maybe don't need to be here, right? And are we able to craft a system that can keep them local? Not only can they still get the care, but then they can convalesce there, which is close to home and close to their family members. So I think that this is going to be a problem that you could certainly make a career out of investigating the solution to. But I don't know if it's all going to be brick and mortar like they've done at Michigan and Maryland and now at UC, or it's going to be other more hybrid solutions or ED-based ones like the ones at Stanford. But I do think that this is an issue that you can definitely make a career out of attempting to tackle within your system.
Okay, my last question, and Dr. Jones, if you wanted to chip in for some context as well, please do. So this is from someone. It says, I went to a critical care conference at my hospital, and there were Palm Crit Care physicians from other hospitals there, and it seemed like they felt that an EM critical care fellowship would not prepare you to work at MICU at their level. Are there any specialties that still don't accept the validity of this training?
This question makes me very angry, but I'm glad it has come up. So when I was in medical school, which admittedly was all of like 10 years ago now, but like I was told EM was not a valid way into critical care medicine. I will say, and I think probably some people will back me up on this, you can tell the difference between pure critical care trained people and people that are trained home crit, in terms of their comfort with critical situations. I don't know anything about the lungs that does not have to do with the patient being on a ventilator, other than like steroids, which I think most of us can figure out, right? But I think anytime that somebody comes up to you and says, hey, diversity in training is a bad idea, that is a huge, huge, huge red flag. I trained with hepatologists, I trained with nephrologists, and they trained with me. And I will say, coming out of EM, I had a very different set of strengths and a very different set of weaknesses than they did. And I cannot emphasize enough how important it is to recognize that those differences exist, celebrate that those differences exist, and then continue to let people specialize in the way that they want to specialize. It is absolutely untrue that coming out of EM, you cannot be a good critical care physician. There is also very true that there are some people that think the old school way of like, you can't be a good critical care physician unless you're trained in internal medicine. And I think everybody on here will disagree that that is objectively not true. EM residents are ranked higher when we apply to these programs, just because of, I think it's just the mindset with which we approach things. We tend to score higher on the boards. So please don't let any clearly very yucky person discourage you from doing this.
I would respond to that question in a similar fashion and say those who still posit that opinion are of a dying ilk, and are dinosaurs looking for tar pits. That's just not the state of the future. And critical care is multidisciplinary now, and no one boxes each other out at the highest level. So perhaps that wasn't a program that really was apical in its community, because that seems like a very unusual stance to take. There are certain diseases in the MICU that I really don't want to take care of out of humility. The advanced pulmonary hypertension patient on a Remodulin drip at home who's having a worsening problem that doesn't require ECMO isn't really the person I want to take care of. And I'm going to call the pulmonary hypertension people who live and breathe this all day, because I should. The same way they're going to call me for a TBI with a bad lung, right? And I think that we just have to recognize the humility in this. That humility was not part of older critical care, right? For generations, that was the end of the road, and there was no one else to ask. So I think that we're evolving beyond statements like that. And I would just say, for someone who's in an institution like that, seek out friendlier skies. There are plenty of places where those aren't going to be the sentiments that you have to live with, and then go back and teach them after you're trained elsewhere.
Got a question from someone who's been on a similar note. I've seen a few hospitals that only have openings for pulm crit trained physicians. From your perspectives and with friends in critical care in other states, what does the job outlook look like for EM critical care fellows?
This is probably one of the number one questions that I get from residents, other than should I look at an anesthesia or an IM based program. I think a lot of the reason why you're still seeing a lot of pulmonary crit care jobs posted, much more than the critical care jobs, is that if you're working at a medium or small size hospital, you probably don't have the volume to support a full-time intensivist, because when you have the intensivist there, you still need somebody that's going to be looking at these pulmonary patients and dealing with the pulmonary hypertension and the nodules and this, that, and the other. The other part of it is that, at least from my perspective, I think that the pure crit care jobs, as well as the people that want to do crit care and emergency medicine as a hybrid, you're going to end up at these larger institutions just because it's a volume issue. And there's also a practicality of the FTEs. When I first graduated, there were lots of places that said, oh yeah, we'd love to have you work in the ER here, and if you want to work in the ICU, great. But the problem was that there was the medicine side, the ICU side was run by a completely different company or hospital than the ER was, and they couldn't find a way to split the FTE. So I would have ended up having to work full-time in one place and then part-time in another, just to make it happen. So finding a place where you can, take that FTE and say, okay, I want half of it downstairs and half of it upstairs, is still a challenging thing that you're, I think, mostly going to find at the larger centers. And when I'm looking at the panel here in the room, we have a lot of large centers represented. In fact, I think I'm probably from one of the smaller ones. So anyone else have any additional insight on that?
I definitely think you have to be thoughtful about the way you craft your narrative as you look for that job. And I agree, right now, the community is actually probably a harder sometimes sell to go into than like a lot of the academic positions. But I think, first and foremost, you have to understand critical care is hungry for doctors, right? If you think there's a shortage in critical care, undoubtedly so. So if you're leaning into critical care, it creates lots and lots of opportunities. There are still plenty of knuckleheads out there that share the sort of opinions of people, some of the things we've already heard of, like, you're not as well trained. I trained longer than most of my critical care colleagues. So like, it's a dying breed. But I think you have to have a good sense of what is right for you and what is wrong for you. Some people are doing critical care to leave EM. Some people are doing it to become better EM doctors. I think there's a lot of flexibility. I think if you end up being the person that's like, I have one dream job and it must be here at this place, you should look at that milieu and get a sense of whether or not it's run by old school folks who aren't ready for EM critical care, or, the otherwise. The best piece of advice I ever got, though, was only work for one person, right? Make sure that you're going to get a job with a single boss, not two, because one of the things I have discovered, and is your critical care boss always thinks that you're just off when you're working in the ED, and your ED boss always thinks you're off when you're working in the ICU. And so making sure that one of those people is clearly your boss, so that you're not working every Thanksgiving, Christmas, New Year's, or only working weekends or something like that, is really integral, I think, when you're going to split your time in two fields that potentially don't always have crosstalk or don't own a unit or a particular space for your ICU time.
I cannot echo Dr. Stull's comments enough. Been doing this a really long time now, and it's very, very important to make sure that the people you report to understand what they're each asking of you. I certainly have done periods of time in my career where I worked a 0.8 crit care and a 0.8 EM because they weren't talking. And it turns out that's a lot, and that can burn you out pretty quickly. And if you're not getting the appropriate credit for time served, especially when it comes to holidays, your family will never see you on a 3-day weekend in a calendar year. That's totally uncool. Unfortunately, the majority of systems don't hire you as a systems employee. You're hired by an individual academic department. So you have to get the crosstalk. And what I'll give you as advice is, it's not the chairs who need to talk. It's the executive directors of business administration. It's your EDBAs. They need to talk, and then they will tell the chairs what to do, because the chairs have an idea of what a chair is supposed to say. It's actually not generally that relevant when it comes to this particular thing. They need to be handed a contract that's integrated so they can make a final decision with a pen stroke. The EDBAs are your friends.
Yeah, I think I agree. To the person, if it is like, hey, I want this one job, and they say palm crit, reach out and be like, to the point that it comes down to how the contract is written. If there is just an inertia that, hey, we've only done palm crit and this is what it is, and you're like, well, I can do critical care, and that also meets the need, then it's a very easy contract if you, get to the business admin side, what this looks like and have it spelled out. So I think there's a lot of legacy and inertia there. Or, to Dr. Case's point, they may be looking for someone to do palm clinic too, right? And then maybe you're not that human, or maybe you have to figure something out and rewrite that contract in a way that actually suits your skills. But to Dr. Stoll's point, if that's the place that you want the job, it's probably worth a conversation with the BA and the hiring folks of what exactly are their needs and can you actually meet them? Because you may or may not based on that conversation. But I wouldn't not apply just because there's one bullet point saying Palm Crit only. Who knows if that's actually valid?
I do want to
And to
caution
what-
people that are planning on splitting a job between EM and CCM to go to institutions that have just critical care doctors or EM and critical care doctors, because if you're going to a place that is just Palm Crit, like only accepts Palm Crit doctors, every single one of those doctors is IM trained. And you may not get the mentorship that you want for the career design that you want. And again, I've never worked at an institution like that, but mentorship is so important in fellowship. And they may just not be equipped to get you where you want to go if a split career is what you want.
Definitely don't be afraid to reach out. I'm glad to hear that CCM is in such high demand. I personally have been out of the job market for long enough. I'm a little bit out of touch in the current state of things. But I will say that a lot of these groups and a lot of these institutions may be in a state of flux. They may really want a Palm Crit care person, but at the same time, they may have a current Palm Crit care person who says, you know what, I'm getting closer to the end of my career. I really would like to step down from the critical care side and just do inpatient pulmonary and office-based practice. So they may be able to, shift some things around and actually create that position for you. So definitely, feel free to reach out and say, hey, this is what I bring to the table. And you may actually open up additional doors that they didn't even realize that they needed themselves.
Really appreciate all your feedback, everybody. That was great.
Yeah, that's awesome. Anybody else have anything to add? I'm out of questions on my end. I know we're about out of time as well. Dr. Jones, did you have anything to add or say?
No, I think that was great. I think that answered pretty much everything in 58 minutes.
Nice.
I think the other thing to add is this is still a small and nascent community where we're very interested in spreading the gospel, as it were, and helping folks up and pulling people up the ladder as we ascend in our careers. So please don't hesitate, to reach out to the folks on this panel because we all volunteered to be here. So I'm sure we're welcome to helping folks to follow in our path.
Totally agree. That's one of the best parts about this very small, very tight community of EM intensivists. Back in 2006 at SCCM, when we had our EM interest group meeting or section meeting, there were 33 of us in the room. That was it. And you look at where we are now, where we're more than 600 strong. Everyone's just an email away. It is a spectacular growth. And please reach out.
Thank you. Yeah, I'll be sending this out to some of my friends who are interested. Appreciate it.
All right. Well, thank you all for joining us. I'm going to go ahead and stop recording.